Now we have to go to the final of the 2 days. I think Dr. Abdullah Shehab will summarize for us all what is about the management of heart failure in 2021 based on all the data coming from the European Society of Cardiology, what we are hearing in the last 2 days, I mean today and yesterday. And Dr. Abdullah is very well known for all of us.
Thank you very much, Dr. Sharif. Actually, this is an industrial symposium, but I actually put some data about the diabetes. This is supported by Novartis. And the good thing, when you've been to a meeting like this, everything you need to know, you already know by now. Okay, so what I'm going to do is just, these are the three things try to bring to the table. Essential role of ARNI in HFrEF management, the position of ARNI in 2022 from the both guidelines, American and European, and then we see, what happens lately, in UAE. We learned today from our colleague before that CKD is very common in heart failure. We also learned today, after just few seconds ago, by Dr. Muhammad, diabetes is also very common. To have these two together, of course, that's the even worse news. We learn over these 2 days that the pathways, 5 pathways we know for heart failure, and good thing, there are 4 medications to play role in these, and these are the guidelines from American. You can see the ARNI plus beta blocker, and then you have the rest, depends on the heart rate, depends on the blood pressure, depends on the GFR. And then you have, of course, the new definition of heart failure you learn from the European guidelines, which is really standardized of the heart failure syndrome definition. We give you more kind of bring us back to what we do with our patient. Symptom signs approach with structure and functional. Then, of course, to risk stratify your patients. Is it because very important not to just wait until patient got heart failure, and to prevent it, and that's stage A and B. That's very easy for us to understand. And we learned actually today, over these 2 days as well, the ejection fraction below 40 is HFrEF. 40 to 50 is mild reduced, which we used to call MERF, and then above 50 is the HFpEF. But I'm sure this is going to change. I'm sure they're going to bring it HFrEF up to the 50, because that makes more sense to me. Then, of course, is that help us to, how to diagnose, how to monitor, which medication to use. And then we need to forget about stable heart failure. Nothing called start heart failure. This is, either persistent rather than, or remission. That's what we should say. And we learn from Canadian, this is also similar to what we have. There's 4 pillars, then depends on what the 4 pillars to start, and Dr. Sharif and others says how to do that. Of course, that depends on your experience or your, availability of these medications, your patient affordability, and many things into it. Then you go down to what's, depends on the heart rate, depends on GFR, blood pressure, to choose what next, or together. And of course, we learn the 4 pillars are class 1A. That means consensus among everyone. And of course, diuretics always there because that helps the symptoms wise. And this is more detail of the European, where to go for devices, CRT, transplantation, all that depends nicely in one table for you. The most important thing I think we all suffer from is the readmission of patient with heart failure. And this is really I don't know. It's very difficult. Difficult for us as a physician, difficult for administration, and when they say to put 4 medications together, is for that reason. Is to prevent to some extent the patient come back. So we have to monitor the changes in we learned all comorbidities today. We learned about iron, learned about kidney, about diabetes, anemia. All that's important because that's need to, every time assess these to come to the. Then of course Rosano's not here, but Rosano come to us with this personalized medicine. When you see a patient with heart failure, you want to start this 4 medication. Yes, fine, but how? Based on these criteria: heart rate, blood pressure, and the patient with atrial fibrillation or kidney disease. All these are very important. Right, so we learned the 5 pathways. One of the important pathways was discovered few years ago, and that was naproxen and the sympathetic and ARAS itself. So here comes, I don't want to go over this because the adverse effect is well known. I want to just take you back 6 years back when we had paradigm shift. It was really paradigm shift in our management of the heart failure, where we discovered that, you know, having this sacubitril with valsartan versus in lateral, this is randomized clinical trial, large number, improvement in everything. You see reduction, 20% in death, and first heart failure hospitalization, reduction in sudden cardiac death was very important, 16% reduction in death and any cause, and 23 readmission, of course, and quality of life. And that's, of course, on top of that, what we know at that time, beta blocker, MRA, and of course, diuretics. Quality of life is important. You heard from Omar Hallak today. The quality of life, you know, with using that iron medication replacement for heart failure, you improve the quality of life. And that's you can assess that by KCCQ. So then experts thought how this medication work. I mean, we need to know the mechanism. Dr. Sharif always asks, SGLT2, how it works? We don't know. Of course, one day we'll know. But at the moment, we don't know. But we know it works. How this sacubitril valsartan works, we don't know. We knew that it reduced the BMP, NT-BMP. But how that effect on other hemodynamics or not? I mean, remodeling, for example, we heard about remodeling. We know that reducing that, will that affect the remodeling? And this was the way to assess that by doing a study called Evaluate Heart Failure, and all the structure and from baseline compared to 12 weeks improved, similar to Prove It as well. Prove It was similar kind of a study, and that showed all the parameters, those experts in echo, you'll see that improvement in that. So that remodeling, of course, results in improvement in ejection fraction. Improvement in ejection fraction, we know it will reduce or improve mortality. I don't want to go on details of this. This is what exactly I said to you. And that's the good thing about this Prove It is not only with the paradigm shift, we have to bring the patient on the optimum medication tolerating before they enter the study. And Prove, no, we just any dose of this interest, or they able to tolerate, the patient was welcomed. And we've seen the effect of that on their hemodynamic and their NT-proBNP. So that's good news for us as a physician, because we cannot every patient put them on the 200 twice a day. 100 twice a day is still good. 50 twice a day is still good. And what I do in my real life nowadays. What about the other de novo patients who have never been on any of these medications, also being tested in this study? And that's again reassurance. That's this is going to work. And we had another study, which so the paradigm shift was on chronic heart failure. What about acute heart failure? Those stabilized, Pioneer, and that showed also it's safe. This medication is safe. That's what we know. Can we start this in the hospital? Yes, we can do that, because once you do that, we learn our GP or somebody, other doctors will continue this medication. If you don't do, nobody do your work. So that's about HFrEF. Well-established, outstanding results from this medication. What about HFpEF, which is, we think, now we modify it further, but in the past, we used to call anything above 40, ejection fraction 40 is HFpEF. Okay, so, and this heterogeneity of this problem, phenotypes, many things we don't know what to tackle. That's difficult to HFpEF. We are learning. So we have evidence for the HFrEF. HFmERF, we learn, and we know there are some medication coming, and we have now, I'm going to show you on sacubitril and valsartan, and maybe HFpEF. I will maybe just give you a highlight of that, because not in the guidelines yet. So until just maybe 2016, 2019 only we had this. The studies, which is maybe there is some evidence of HFpEF improvement by MRA or by ARBs or by ACE inhibitors. What about sacubitril valsartan? There are some studies before done, but the biggest one was Paragon HF. And this was to test if this is going to work in patients ejection fraction above 40. And this is the design of the study. I don't want to go through it, but the results, primary endpoint, just missing the 0.059. Of course, if it's 0.05 is fine. So it was kind of hypothesis generation, but when they looked into to see where the benefit, hospitalization, but then they looked at sub-analysis to look where the interactions is, you see the best, where you can use this medication. Again, it's hypothesis generation. They found it in patients who are female and with ejection fraction up to 57. So that's maybe, we can still call that with the new data you learned recently by SGLT2, that maybe up to, that 60 is still ejection, low, maybe low ejection fraction. We don't know, we're learning. So that was the outstanding the female and with low, with up to ejection fractions 57. And that's clearly seen when they looked, the benefit of this medication get attenuated when you go just above 57. So this was the position paper from American, and says Novartis announced that the U.S. Food and FDA has approved the following expanded indication for this medication to reduce the risk of cardiovascular death and hospital for the heart failure in the adult patient with chronic heart failure. Benefits are most clearly evident in patient with left ejection fraction below normal. Okay, the normal that's called here 57 and below. This is what they meant. The label also states left ejection fraction is a variable measure, and clinical judgment should be used in deciding whom to treat. Of course, the more details you can see in the notes. So now we have this Paragon, and you can see reduction, the primary endpoint by 13%, missed the endpoint. Of course, with the new data come now, we have, we had this one, beta block, then come the positive trial of SGLT2, you just heard from IMPA, and now we have IMPA as there, and mainly in what? Remember, I started with that, hospitalization, not on the outcome. Until now, we don't have anything on death, on the outcome. So the rehospitalization is very important. Maybe they missed the points, but until now, the guidelines tell there's nothing about SGLT2, about HFpEF, but there is something about secretary valsartan. Of course, there's a new study coming about SGLT2 and deliver. I think that will be in ACC next year, and some devices, and GLP-1 as well. So the guidelines there to give us a breadth and depth of the existing therapies in HFrEF, we've seen that clearly. And the summary, the essential role of ARNI in HFrEF management with superior efficacy, you've seen that from all the study I showed you. The strong position ARNI in 2021, we already showed you as well. Based on new approval of label in the region, Paragon HF trial, this medication has got great benefit on those heart failure patients with ejection below normal, which is below 57, which gives solution to heart failure with reduced ejection fraction. That's one I don't know how long will be up to what ejection fraction. We're going to learn more, and many HFpEF possibly in future. So that was the final talk of today, and I hope over these 2 days we'll learn together, and the interactions we had, and I think the 600 attended this meeting with Prof. Rosano and his colleagues from European, and of course from the Gulf, and your presence, your interaction really made this beautiful. And thank you guys as well. Sherif, you want to say something?
Thank you very much, Dr. Abdullah. First of all, I want to thank you for this marvelous, excellent 2 days of knowledge. And of course, there is a lot of preparation, a lot of effort. So we have to thank you for that, for allowing us to have this very knowledgeable symposium. Can I ask you very quick questions and a very quick answer? Now we have the heart failure with reduced ejection fraction. What is the first line treatment if you am talking about the ARB, ACE inhibitor, or ARNI?
To be honest,
for your patients.
Yeah, to be honest with you, doctor, I actually started, 2 medication, and I use it without even thinking nowadays. SGLT2 and ARNI at low dose. That's what I do with my patients.
I think. Now we'll go to the second. If somebody, you saw him, I'm talking about de novo, but someone was on the reduced ejection fraction, but was not on ARNI. Are you going to shift the other to ARNI, or you continue what he has?
Sorry, patient
And
on
if
what?
he is, for example, on S inhibitor or ARB. So you saw him, and he is reduced ejection fraction.
Yes.
Do you prefer to continue on what he have, or you prefer to change him to ARNI?
Without hesitation, if patient able to afford it, and now we have this system by Novartis, they're helping us.
to
I'll
support,
do it.
yeah.
Yes, I will definitely do it. Yes.
To be honest, this is what also I'm doing. I mean, if anybody want to comment, Doctor, anybody want to comment on this,
I think they're happy.
the plan?
They're happy. They're happy.
Okay, I think it is, now the gray zone will be with preserved ejection fraction.
Exactly.
And this will be kept, I think the SSG2 have added a lot of enthusiasm on this.
MRAs, they have a study going on.
Yeah.
And there are some devices coming, and who knows, and GLP-1 coming as well. We don't know. I mean,
Yeah.
there
Thank
are
you
good
very
news.
much. It was
Thank you very
excellent,
much.
excellent. Thank you.
Thank you. مشكورين.